previous speaker has taught us strain and strain rate without any strain. So I will make my slides a little bit faster because he has elaborately discussed about the strain rate. Before that, I want to thank the organizing secretary for having given me this opportunity, because in one of the pamphlets they said, learn while doing echo, we learn while doing teaching also. So respected, I should respect my teacher, Professor Alagesan and Vijayaraghavan before I start. And today we are here to know about strain, because he has talked about the strain rate already. What is the need for the strain and what is it, and is there any clinical relevance to the day-to-day practice, whether it is going to be applicable to our day-to-day activities. During the evolution of echo, we have seen from A mode, B mode, M mode to up to this point. So far we have achieved so many factors regarding hemodynamic parameters, ejection fraction, cardiac output, and stenotic, how severe the stenosis is, regurgitation, shunts, left to right shunt, all those things. We achieved a lot during these past decades about the hemodynamic parameters. There was an absolute silence of 1 decade after this, during which they studied a lot about this tissue Doppler, strain rate, TSI, etc. Why they opted for this tissue Doppler imaging? That is the main secret. We have in the heart, main component is myocardium, the another component is blood. That's all. The myocardial component has got enormous reflexing intensity, but velocity of the myocardium is low. And on the other hand, RBC flow is very fast, but velocity of the reflection intensity, because small RBC intensity is very small. We have got both component contrasting within the heart. One is slowly moving at a very slow, intensity is high. Another is moving very fast, intensity is slow. So we have to compromise at one point of time. So up to 2 decades ago, we had all the echocardiography machines which willfully suppressed the myocardial signals, thinking that is going to give artifact to the hemodynamic parameters. So they have suppressed using the filters, the myocardial filters are used. Only the blood component is visualized and it is colored blue and red, and we were enjoying the color flow Doppler imaging. Now, people thought we want to gain something about the myocardium. Why we are interested in knowing the myocardial strain and strain rate of this level? Because the molecular, enzymatic, molecular changes and all these physiological and pathological diseases alter the myocardium well in advance before the blood flow signal falls. That means if you know about the myocardial information or myocardial language, you can identify the disease 1 decade earlier than the degree of fall of ejection fraction. That means if you know the myocardial language, you can identify the disease very well in advance before the disease progresses. That is the basic of understanding the physiology or pathology or the echocardiography of myocardial imaging. Now, we suppress the blood signals and we are only interested in the myocardium. That is the basic of myocardial imaging. This was done by McDickan and Sutherland some 20 years back. And we know the importance of tissue Doppler imaging, but it has got inherent limitations. It has got angle dependency. Noise interference is one of the biggest disadvantage. Substantial intra and intra-observer variability is there. It is being affected by cardiac translational movement, this tissue Doppler. When you put a sample volume here, it is not static, it is myocardium is moving, so you will be wrongly interpreting in some other area. Because it is sampling volume is constant, the myocardial segment that is moving, that will give you a wrong information. But it only gives you information about the longitudinal strain. But we have got other strains that's called radial strain, circumferential, torsion, rotation, etc., etc. But of all that, if you put a sample volume here, it will give you beautiful tissue Doppler imaging here, but this is an akinetic segment or contracting, not contracting properly, but it is pulled by the normal tissue. This is called a tethering event. So the disadvantage of tissue Doppler is velocity data do not differentiate active contraction from passive contraction. So these are all the disadvantages of tissue Doppler imaging. Now we will go to the 2D strain imaging. This is otherwise known as speckle tracking imaging. This has no angle dependency, no noise interference from the blood, minimally affected by intra and intra-observer variability. This is the most plus point of this. This is the best part of the speckle tracking echo. Not affected by cardiac translational movement, highly reproducible. So this is what it stands. When the test is highly reproducible, it stands. Complete analysis of cardiac mechanics, longitudinal, radial, circumferential, torsion, rotation, everything is possible with speckle tracking, otherwise known as 2D strain imaging. What is its efficiency? It is myocardial strain derived from speckle tracking is well validated using sonomicrometry and tagged MRI. We know this is the gold standard of cardiac imaging. Already being discussed various layers doing various performance. And this is the longitudinal strain that is contracting from base to the apex. This is a radial strain contracting towards the center of the left ventricle cavity, and this is a circular perimetric contraction that is done by the short axis in the circumferential strain. These are all various components of the strain values. This is the longitudinal strain which we are more interested because the longitudinal fibers are situated subendocardially, being affected in 85% of the times. In all the cases, 85% of the cases, the longitudinal strain that is affected first. So if you know about the longitudinal strain, you know about 85% of the disease progress. How about 20? This radial and circumferential strain will tell you about the rest of the stories. Already it was the physics of deformation and strain rate discussed. When a tissue moves without altering the shape, this is called displacement or translation. When the tissue alters its shape, this is called displacement with deformation. The degree of deformation is known as strain. The rate at which it deforms is known as strain rate. That's all. What is this speckle tracking? When the ultrasound beam meets the myocardium, it gets some physics changes. Reflection, scattering, and interference of the ultrasound beam as it touches the myocardial fibers produces bright spots which are 20 to 40 pixels in size, very small dots. They conglomerate to produce some such structure called kernels. All these structures can be tracked throughout the cardiac cycle, and that this is possible. Throughout the cardiac cycle, systole, diastole, everything is possible. We can track about this, and this will give you information on the 2D grayscale imaging. That is the secret of speckle tracking imaging. This is otherwise simply texture tracking image. That's all. So this is the longitudinal imaging, parasternal long axis view, apical 4-chamber view, 2-chamber view. We have got so many numbers which gives you the regional as well as global information. That is again one more advantage of longitudinal strain is it gives you overall picture of the cardiac performance. At the same time, it will give you the segmental information also simultaneously. So looking at the particular segment, we can deduce something, this is wrong with that segment. That then simultaneously overall performance can also be achieved. And for normal individuals, healthy myocardium, it looks bright, overall performance is bright red. Whenever there is alteration in red coloration, that is discoloration of the red, that denotes some strain abnormalities. We have to carefully look at that. This is called a post-systolic index. The importance is the percentage of post-systolic strain values compared to the maximum strain peak value. This is more important as far as the infarction is concerned, coronary artery disease is concerned. So far we were identifying coronary artery disease based on this. When we get a scar tissue that is thinned out, and bright echogenicity, this is a manifestation of coronary artery disease. Whenever one area is contracting nicely and other area is fails to contract normally, failure of systolic thickening is a manifestation of coronary artery disease. And some area is moving, some area is not moving. We used to generally call it as regional wall motion abnormality. So there are so many inter-observe. What is the difficulty in identifying coronary artery disease so far? It approach is highly subjective. For me, it may be akinetic. For you, it may be hypokinetic, like that. It requires operator experience and depends on the image quality. 2D image quality, when it is fine, you can venture on these modalities. If you don't get better endocardial border or 2D imaging, don't attempt to do all those sophisticated modalities. The basic bottom line is good endocardial border with good 2D imaging. And now, the ischemic and scar tissue shows not only reduction in the amplitude, but delay in the peak segmental strain. This post-systolic thickening occurs early after the onset of ischemia. This is the earliest event. How do you identify this? So this is the end of this, the descending limb of the T wave. This is the end of the systole, and after the end of the systole, you get a systolic curve, systolic peaking. This is called post-systolic peaking or post-systolic thickening. So this post-systolic thickening is present when the aortic valve is closure. That means this thickening occurs at the expense of early diastolic event that is called isovolemic relaxation. Normally, the contraction should stop at the aortic valve closure. Contraction prolongs after the aortic valve closure. That you identify that is the evidence of coronary artery disease. Easy. Look at the wave and you can identify it. This is a patient with chest pain and doubtful anteroseptal region STT changes. Look at the wave pattern here. These are all aortic valve closed areas. This is velocity is fine. In this curve, the velocity is reduced and delayed contraction after the aortic valve closure. That means looking at the curve itself, I can say this is an ischemic segment. That's all. Straight away, you look at the waveform, look at the color and segmental mark. Look at this normal 21, 18 to 21 mark. This segmental delay, this is -3. There is an enormous reduction in the segmental strain also. So looking at this mark, looking at this curve, I can say we are dealing with coronary artery disease. This is an anteroseptal. So looking at this tissue speckle tracking imaging, this clearly shows anteroseptal infarct. Not only that, it gives some more information. The color which is blue, that means when there is systole, it should be like this. The diastolic component should not come. That means this blue component is a positive component. Whenever there is contraction, this component is bulging outside. This is lengthening. So this component is likely to be dyskinetic segment. In other words, this area is going for aneurysmal formation. So this is the post-systolic index. This should tally with this. Then only we can say we are dealing with coronary artery disease. If this is not tallying with this, that means myocardium is straining, but not due to coronary artery disease. So this is an anteroseptal infarct. So post-systolic thickening. Not only that, identifying infarction is not the material now. Now we are interested in knowing which culprit artery is involved. We can identify the artery that is involved. Look at the basal septum. That is septum, inferior wall and posterior wall. We are dealing with the artery territory of right coronary artery territory. So we are dealing with right coronary artery infarct. So not only that, looking at the right ventricle, somebody asked about the right ventricle. We look at the right ventricle. Right ventricular contraction is normal. That means this is an isolated inferior valve infarction without right ventricular involvement. On the other contrary, we have got a same inferior wall infarction. Look at the right ventricular strain. That is also affected. That means prognosis is little bit guarded and poor. Because apart from inferior wall, we have got right ventricular infarction also. So this is an inferolateral STT changes. Look at the area of infarction. It is in the lateral component. That means before going to the cath lab itself, I can say this is the right circumflex that is dominant. That circumflex artery is going to be affected. This has been well validated by angiographic representation. Coming to the crucial aspect, whether we can identify ischemia from infarct. What is the gradation of ischemia? Nobody has given a concrete version about the numbers, clear-cut cutoff numbers, but there are certain references. The radial strain, the cutoff value is 16.5. This identifies non-transmural from transmural infarct. Circumferential strain less than 11 minus 11, thus denotes transmural infarct rather than transmural, non-transmural. Longitudinal strain less than 5, that denotes this is an infarct segment. But what is the difference between ischemia and infarct by speckle tracking? Only the longitudinal strain that is affected, but rest of the strains, circumferential and radial strain, everything, rotation, everything is intact. That means this is an ischemia, not an infarct. When all the parameters are affected uniformly, that means we are dealing with infarct. So these are certain references. Not only we are identifying infarct, at the same time we are using this speckle tracking for prognosticating. Longitudinal strain less than minus 0.2, mean 10.2, after following reperfusion predicts non-viable myocardial tissue. That means if you revascularize, we are not to gain much after the revascularization. And global longitudinal strain 15.1 and strain rate minus 1.60, 5 times risk of all-cause mortality and risk of secondary. So not only we are identifying the artery component, not only we are identifying ischemia from infarct, we are also we are also giving you the prognosis on mortality and morbidity rate also. And Becker et al. Told that peaks radial strain 17.2 is the cutoff to predict functional recovery. If you get a radial strain more than 17.2, then you can boldly go with the revascularization. Functional recovery will be very good. So now we have identified the coronary artery disease, area of coronary artery disease, the artery involved, and the transmurality, whether it is ischemia or infarct, whether we can predict whether it is a viable myocardium, whether we are going to achieve after revascularization, everything we can deduce from speckle tracking echo. And this is strain rate imaging. We don't, initially enthusiasm has declined enormously because strain rate has got so many inherent disadvantages. One is noise signals. We cannot interpret it. This will give you confusing picture. And this is again, we have to get different images at different time to get strain images. And on the other hand, the longitudinal strain, I can put you the probe on only one position. I can get all the information, triplane imaging, so that there is heart rate is constant. Once in the single space, I get all the information. Whereas for radial and circumferential strain, I have to get at the mitral valve level, I have to get at the papillary muscle, I have to get at the apical level, but at different timings, at different heart rate. Here the heart rate is 88, here the heart rate is 90. So this is not valuable and this is not well validated because different positions and different timings and different levels we are screening, radial, circumferential, etc. On the other hand, one single image with single heart rate that gives you all the information about the coronary events, all this information. Apple may look outside healthy, but inside there may be a problem. ECG may look normal. For 2D imaging, this is an absolutely normally contracting 2D images. I could not make out any regional wall motion abnormality. But when I put the speckle tracking, there is an lower 1/3 and lateral wall severe coronary artery disease is there. So ECG may be normal. I can identify in an asymptomatic individual. So here, patient with chest pain, sweating, vomiting, giddiness, and left shoulder arm pain, typical ACS manifestation. I can do speckle tracking at the triage itself, emergency department. Here in this case, STT changes inferior and anterior leads also there. So I cannot neglect this patient as non-coronary. Look at the speckle tracking on this individual, complete red, complete pale blue. That means totally myocardium is normal. We are dealing with cervical spondylosis with radiculopathy. In the triage itself, I can dismiss the patient. This is not the coronary patient. I need not unnecessarily put him in the ICCU and tax the patient. So this is the very good secret of doing this speckle tracking at the triage itself. So now speckle tracking is used as ischemia screening test at the triage itself. That is the more powerful utilization of this machine. Look at this ECG, non-specific change, but my speckle tracking shows something wrong with the apex and lower 1/3 of the anterior IVS. This confirms we are dealing with distal LAD territory also. The second day ECG only shows ST segment elevation in the high lateral and anterior walls. So ECG may not give you truth in the beginning stage, but this will give you concrete information well in advance, whether to go for thrombolysis, whether to go for revascularization procedure, looking at this speckle tracking alone. So now speckle tracking is used as ischemia screening test once again. Coming to the valvular disease, is there any use of speckle tracking in the valvular diseases? This is an aortic stenosis, the typical concentric LVH, severe aortic stenosis. The ejection fraction is somewhat around 74% ejection fraction. That means this AS patient has got very good ejection fraction. But unfortunately, speckle tracking tells you there is a global deterioration in the longitudinal strain. See, normally it should be more than 18. Any value below 16 we should be cautious. Lower the value, higher the damage of the subendocardium. So this patient is already suffering from subclinical LV dysfunction, but ejection fraction is apparently normal and giving you a false sense of security to you. Again, aortic regurgitation. This is the pressure half time less than 200. This is descending aorta pan diastolic reversal, abdominal aorta pan diastolic reversal. No doubt we are dealing with severe aortic regurgitation. Ejection fraction is normal. Looking at the speckle tracking, I can tell you that this aortic regurgitation patient has got subclinical LV dysfunction. Again, mitral regurgitation, normal ejection fraction, subclinical LV dysfunction. What is the fun in doing all those things? Now people are thinking, when you submit this patient at this level itself, your post-operative events will be uneventful. Patient will have a very good, pleasant, without less morbidity and mortality. People are thinking on that line. So before don't wait for the ejection fraction to fall. After that, if you submit the patient, the post-operative complications, morbidity and mortality will be more. So if you pick up this patient at the subclinical dysfunction itself, we can save so many individuals. So similarly, the same pattern can be identified by hypertrophic cardiomyopathy. Coming to the hypertensive heart, normal ejection fraction, asymmetrical concentric hypertrophy, and E by E prime, you know that this patient is complaining of exertional dyspnea, that's all. Any patient who complains of exertional dyspnea, you should be careful because we are dealing with heart failure with preserved ejection fraction. That is the earliest manifestation of heart failure with preserved ejection fraction. So at this point, the ejection fraction is normal, but be careful, E by E prime is more than 15. That means elevated LV EDP. But look at the global strain. That means overall performance is gradually reducing. That this patient is having heart failure with preserved ejection fraction. Looking at this value itself, I can tell you, I can identify these individuals. Look at the diabetic patients. Normal ejection fraction, 60%. Patient is still asymptomatic, but global longitudinal strain is reduced grossly. That means apparently this diabetic individual is normal. He has subclinical LV dysfunction. If you identify these people and put them on carvedilol or ramipril, whatever AC inhibitors, we can prevent the drastic outcome of cardiomyopathy, diabetic cardiomyopathy. So that is the advantage of doing speckle tracking. So in a day-to-day practice, we can apply this speckle tracking. This is not a sophisticated modality. You can apply for day-to-day event. So this is a post-chemo patient, grossly worsened ejection fraction. That is less than 15%. This is not the way for the chemotherapist or the oncologist to send the patient to the cardiologist. We have to screen this patient well in advance. So this patient underwent post-chemo Hodgkin 6 cycles vinblastine and bleomycin, totally asymptomatic. the ejection fraction is normal. Speckle tracking identifies subclinical LV dysfunction. So all these chemotherapeutic drugs that damage the myocardial segments, titin, that is the cytoskeleton protein that is affected by the chemotherapeutic agent first. Then the reactive oxygen species and superoxide and hydroxyl ions, all these things damage the myocardium. So subclinical LV dysfunction, the early marker of chemotherapy induced myocardial dysfunction. What is the fun in identifying subclinical LV? Now, along with chemotherapeutic agent, you should put carvedilol for this patient. That is the therapeutic advantage of doing this. Subclinical LV dysfunction in a patient with apparently normal myocardium, you have to put carvedilol. You have to roll off enalapril. They have identified the beneficial role of enalapril on post-chemotherapy individuals, but it is useful when there is decline in ejection fraction. But people are thinking prophylactic carvedilol along with the chemotherapeutic agents, it will prevent the progression of the disease from the injurious effect of chemotherapeutic agent. This is a dilated cardiomyopathy. This can identify the area of delayed areas. This radial strain and radial strain rate is very much useful to identify the pacemaker lead on the exact point so that we can get a very good synchronization and very good outcome. So, till today we have got discrepancies in identifying the area of dyssynchrony. But using this radial strain and strain rate, we can identify the optimal area of delayed contraction, and we can optimize the device therapy so that we will get a more synchronous imaging in dilated cardiomyopathy. So not only the tissue, speckle tracking can be applied to the left ventricle. It can be applied to the right ventricle also. Now we have extended the application of speckle tracking to the other ventricles also. And this is the McConnell signs. The apex is contracting briskly, but the right ventricular free wall is not contracting. This is the -2 and -3. That means we are dealing with an acute pulmonary embolism. That's all. RA-RV dilated, pulmonary artery dilated, apex is contracting briskly, and the right ventricular free wall is not moving. You are dealing with two conditions. One is acute pulmonary embolism, other is right ventricular infarction. That's all. Differential diagnosis 2. Look at this individual. This is a cardiomyopathic patient. Apart from this left ventricle, right ventricle is also, biventricular cardiomyopathic process is a bad prognostic sign. Looking at this inferior wall infarction, already I have shown this slide. Inferior wall MI along with the right ventricular infarct, you can boldly and concretely say this is a right ventricular RCA, proximal RCA involvement. And this is a pulmonary hypertension with a decline in right ventricular free wall dysfunction denotes poor prognosis. Not only that, in congenital heart diseases also, whenever there is ASD, VSD, PD or cyanotic heart disease, when there is involvement of the right ventricle, decline in right ventricular function, you should be very careful about putting the patient for surgery, because the post-op events may not be rosy and patient may not give adequate response to the surgery. Now we have moved from left ventricle to the right, left atrium. Left atrial longitudinal strain also will give you information about the diastolic information as well as systolic information. Normally it is more than 50. When there is hypertension, the left atrial strain is reduced. In diabetics, left atrial strain is induced. In both the individuals, enormous decline in left atrial longitudinal function. So we can apply for diastolic dysfunction also. Now the strain, from the Doppler strain, from the 2D strain, that is called speckle tracking strain, now we have moved to the 3-dimensional strain. This overcomes most of the negative outcomes of 2D strain. One is out of plane movement. And moreover, as I already pointed out, radial and circumferential, we have to get short axis at different levels. Whereas in one single image, one single A4C image, that's all. That will give you all the simultaneous information about the global longitudinal strain, global area strain, global circumferential strain, global radial strain. This is a newer terminology that is called global area strain. This is the future of ejection fraction. Here afterwards, we are not going to rely on ejection fraction, as you know well why we are not giving much importance to the ejection fraction. But global area strain is a true reflection of cardiac systolic performance. If it is less than 30, less than 28, there is a decline in cardiac systolic performance. This is a conglomeration of longitudinal function and circumferential function. This is the best predictor or indicator of cardiac systolic dysfunction. And this, not only that, this will give you the myocardial mechanics in left ventricular with preserved ejection fraction. Look at this hypertensive individual. This is a normal ejection fraction, roughly about 74%. This is three-dimensional rendered ejection fraction is well validated than the two-dimensional method. And I'm not interested about that ejection fraction in this patient, but the ejection fraction is maintained normally for this patient. But unfortunately, when you apply three-dimensional echo, global longitudinal strain is reduced. That means patient has got subclinical LV dysfunction. Global area strain is also reduced. You have to see only two parameters, longitudinal and area strain. How about global circumferential strain? How about radial strain? In the initial stage of heart failure with preserved ejection fraction, which is preserving, that is more important. We are fond of writing something. Heart failure with preserved ejection. What is preserving the cardiac function? The first, any disease, first myocardial segment that is affected is subendocardially situated longitudinal fibers. The second myocardial ray fibers affected is radial strain. Up to this, longitudinal and radial fibers, if they are affected, still ejection fraction will not fall. It is in them the global circumferential and the and rotation segment that compensates to maintain the ejection fraction. When the moment the global circumferential strain falls, your ejection fraction also falls. This is the secret of cardiomechanics. So what is what is preserving the cardiac function is global circumferential strain is preserving. Look at the diabetic heart. Normal systolic function, there is a reduction in the longitudinal strain. Again the same story. The preservation is by the global circumferential strain. Normal value is less 18, it is more than 18. Pardon? So I will tell you, sir. So with the advent of 3D straining, now we are very well comfortable in giving the prognosis as well as the cardiac mechanics. What is happening in all those disease individuals? Now currently we are moving to some other strain. This is called a layer strain. As I already told you, most of these diseases, 85% of the diseases, subendocardial fibers are affected first. So what is happening in the subendocardium? Clearly it points about what is the exact thing that happens in the subendocardium. I want to know what is happening in the mid-myocardium. So this is called mid-myocardial strain. The strain is being separated into various areas. Endocardial strain, mid-myocardial strain, subepicardial strain. Why we are bothered about epicardial strain? For all the diseases, the disease progresses from endocardium to the epicardium. For radiational disease and pericardial diseases, the insult starts from periphery to the center. So, in these radiational radiotherapy individuals and pericardial diseases, if you do this layered strain, if the epicardium is affected, these two are not affected. That means the disease process is crossing the epicardium. It is going to affect the myocardium, and we are going to get an adverse myocardial remodeling. That is where we are here. So I think I have come to the last slide. We started from 2D strain, which has got so many limitations. 2D strain, day-to-day activities, day-to-day purpose, it is useful. 3D strain, it is going to be useful as and when you apply. 4D, this layer strain is the future strain, which is going to give more information about the diseases. Thank you once again.